Good afternoon, dear students. Today we have a lecture according to schedule for students of third year for MM groups who have a second semester of education. And topic of our today's lecture is syndromes of hepatobiliary tract and exocrine pancreas disorders. And it is one more lecture in a subcycle of signs and symptoms of GI disorders. Let's continue our today's lecture. Today we have such a plan to discuss a spectrum of hepatobiliary tract and pancreas disorders, and separately we will discuss hepatobiliary tract problems and exocrine pancreas problem. And here on the slide it is for you remind anatomical structure of hepatobiliary tract and anatomical position of pancreas, its main vessels and its ducts and places where these ducts go to their intestine. In a spectrum of hepatobiliary tract disorders, we going to discuss what can we classify, what diseases can be in hepatobiliary tract. First of all, it is problems with bile ducts and gallbladder. Here we include gallstones, strictures, leaks. It is first of all leaks of bile caused by trauma and surgery. It can be gallbladder cancer, bile duct cancer, cholangiocarcinoma, cholangitis, and cholecystitis. The problems with liver can include many of them. It is liver tumors. Here most often we can see hepatocellular carcinoma, metastatic colorectal cancer, neuroendocrine cancer, and other metastatic tumors. And benign liver lesions like hepatic cyst, hemangioma, adenoma, focal nodular hyperplasia. Moreover, in liver problems, we can classify fatty liver, hepatitis, different etiology. It can be viral and non-viral, and liver cirrhosis. Pancreas disorders include pancreatic cancer, acute and chronic pancreatitis, pseudocyst, and cystic neoplasms. Syndromes in hepatobiliary tracts. It is can be syndrome of gallbladder motility disorder. It is liver size changes, portal hypertension, hepatocellular dysfunction, and cholestatic syndrome. All these syndromes we will discuss today during the lecture. Let's give definition to gallbladder motility disorder. Gallbladder motility disorder is defined as biliary pain in the absence of gallstones, sludge, microlithiasis, or microcrystal disease. The diagnosis is considered in patients with typical biliary-type pain who have had other causes of pain excluded. The prevalence of functional gallbladder disorder among patients with biliary-type pain and normal transabdominal gallbladder ultrasound is up to 8% in men and 21% in women. It is quite often. Causes and mechanisms of gallbladder motility disorders. The exact cause of it is unclear, but it's generally regarded as a motility disorder of gallbladder. It may result from the initial metabolic disorder, like as bile supersaturated with cholesterol, or a primary motility disorder in the absence, at least initially, of any abnormalities of bile composition. It has been noted that patients with functional gallbladder disorder may have abnormal gastric emptying and colonic transit, suggesting a possible generalized gastrointestinal motility disorder. The hypothesis that disorder is related to abnormal gallbladder motility is the basis of measuring the gallbladder ejection fraction as part of the evaluation. Clinical signs. Patients with gallbladder motility disorders present with biliary-type pain, also known as biliary colic. It is quite a specific type of pain. The liver and pancreas blood tests usually in such patients are normal. It will be no gallstones or gallbladder sludge seen on imaging, and upper endoscopic examinations will be normal. Despite the name, biliary colic is usually constant and not colicky. The classic description is of an intense discomfort located in the right upper quadrant or epigastrium that may radiate to the back, particularly the right shoulder blade. The pain is often associated with diaphoresis, nausea, and vomiting. The pain plateaus is less than an hour, ranging from moderate and excruciating in severity. Pain typically lasts at least 30 minutes and then slowly subsides over several hours, with the entire attack usually lasting less than 6 hours. While the pain often develops 1 to 2 hours after ingestion of a fatty meal, an association with meals is not universal, and in significant proportion of patients the pain is nocturnal, with the peak occurrence around midnight. While non-specific dyspeptic symptoms such as indigestion, abdominal bloating, and belching may coexist in patients with biliary colic, they are not usually relieved by cholecystectomy. Lab test, imaging and endoscopic studies, instrumental and laboratory methods of examination of gallbladder motility disorders. Here, patients with functional gallbladder disorders have normal blood test. Laboratory test will be all normal. In addition, abdominal imaging is normal with no evidence of gallstones, gallbladder sludge, or cholesterol polyps. Finally, patients have normal upper endoscopic examinations. And we have a specific criteria for biliary-type pain. How to differentiate with other types of abdominal pain. First, pain is located in the epigastrium or right upper quadrant. Usually, biliary pain is recurrent but occurs at variable intervals, usually not daily. Pain lasts at least 30 minutes. This pain is built up to the steady level. Usually, biliary-type pain is severe enough to interrupt daily activities or lead to an emergency department visit. Pain is not relieved by bowel movements, postural changes, or antacids. Supportive criteria of biliary-type pain usually include usually this pain is associated with nausea and vomiting. It radiates to the back or right intrasubscapular region, and this pain awakens patients from the sleep in the middle of the night. It was additional criteria of biliary-type pain. Let's discuss the next syndrome for today. Its name is jaundice. Let's give definition to jaundice. Jaundice, or in Latin it is icterus, it is a yellowish pigmentation of the skin and conjunctival membranes over the sclera whites of the eyes and other mucous membranes caused by high blood bilirubin levels. Jaundice causes increased levels of bilirubin in the extracellular fluid. Concentration more than 3 mg per deciliter or more than 50 in millimoles per liter leads to jaundice. It is typical clinical picture of jaundice. We told in definition that it is a yellowish discoloration of skin, and very specifically it is coloration of sclera. What you see on this picture. Types of jaundice. There include prehepatic jaundice, intrahepatic jaundice, posthepatic jaundice, and neonatal jaundice. It is 4 main types. Now we will discuss everyone. And here you see a picture with different subcolors of yellow. Why I included here? Because in different patients, depending on type of jaundice, it can be different yellow coloration of skin, mucus, and sclera, from the brown to the lemon color. That's why, and according to this color, you can suspect one or another type of jaundice. Prehepatic jaundice. Prehepatic jaundice is caused by anything which causes an increased rate of hemolysis. Hemolysis, it is breakdown of red blood cells. What it can be? The causes of this hemolysis. It is severe malaria, sickle cell anemia, spherocytosis, thalassemia, pyruvate kinase deficiency, glucose 6-phosphate dehydrogenase deficiency, diseases of kidney, defects in bilirubin metabolism, etc. Another more rare causes. The increased breakdown of red blood cells, which we named hemolysis, leads to the increase in the amount of unconjugated bilirubin present in blood, and deposit of this unconjugated bilirubin into various tissue can lead to a jaundiced appearance. From where it goes bilirubin, unconjugated bilirubin, to blood. It produced by destruction of erythrocytes that contain this unconjugated bilirubin. And jaundice secondary to hemolysis, the increased production of bilirubin leads to the increased production of urine urobilinogen. Bilirubin is not usually found in the urine because unconjugated bilirubin is not water soluble, so the combination of increased urine urobilinogen with no bilirubin unconjugated in urine is suggestive for hemolytic jaundice. And here you see mechanisms and level of jaundice, if it is prehepatic or hemolytic, according to its main mechanism. Intrahepatic jaundice. Intrahepatic jaundice can be caused by acute or chronic hepatitis, hepatotoxicity, cirrhosis, drug-induced hepatitis, and alcohol liver disease. Leading to an increase in plasma conjugated bilirubin because there is impairment of exertion of conjugated bilirubin into the bile. The blood contains an abnormally raised amount of conjugated bilirubin and bile salts which are excreted in the urine. This conjugated bilirubin is then returned to the blood, probably by rupture of the congested bile canaliculi and direct emptying of the bile into the lymph, leaving the liver. Thus, most of the bilirubin in the plasma becomes the conjugated type rather than the unconjugated type. In this conjugated bilirubin, which did not go to the intestine to become urobilinogen, gives the urine dark color. Here you see a mechanism of intrahepatic jaundice, and here you see that the problem on the level of liver, it is hepatitis or cirrhosis or other problems with the liver that lead to abnormal conjugation and abnormal excretion of bilirubin from there, and it leads to accumulation of bilirubin, most of all conjugated bilirubin, that in it can be converted to urobilinogen and urobilin and excreted with feces. Post-hepatic jaundice, or another name of this jaundice is obstructive jaundice. It is caused by an interruption of the drainage of bile containing conjugated bilirubin in the biliary system. The most common causes of the gallstones in the common bile duct, the pancreatic cancer in the head of the pancreas. A group of parasites, we name it liver flux, can live in the common bile duct, causing obstructive jaundice. Other causes include, it can be strictures in the common bile duct, it can be biliary atresia, most often congenital, that obstruct biliary ducts and don't let bile go to the intestine. It can be obstruction due to cholangiocarcinoma, due to pancreatitis, cholestasis of pregnancy, and pancreatic pseudocysts. Incomplete obstruction of the bile duct, no urobilinogen is found in the urine, since bilirubin has no access to the intestine, and it is in the intestine that bilirubin gets converted to urobilinogen to be later released into the general circulation. Presence of bilirubin, here it is mostly conjugated bilirubin in the urine, without urine urobilinogen suggests obstructive jaundice. You remember it was no bilirubin in urine, but present urine urobilinogen for prehepatic or hemolytic, and here it is opposite. It is present bilirubin in the urine, but it is no urine urobilinogen. It is typical specific for obstructive jaundice, either then intrahepatic or posthepatic. The presence of pale stools and dark urine suggests an obstructive or posthepatic cause. Patients also can present with elevated serum cholesterol and often complain of severe itching or pruritus because of the deposition of bile salts. In such way, it looks mechanism of post-hepatic or obstructive jaundice. Neonatal jaundice. It is a fourth type of jaundice. It's usually harmless and often seen in infants around the second day after birth, lasting until day 8 in normal birth or to around day 14 in premature birth. It is a variant of normal. Typical causes of neonatal jaundice include normal physiological jaundice. It's what I told in this normal period, normal days. It is variant of physiological state of neonatal. Moreover, they can be pathological. It is jaundice due to formula supplementation, like for example, groups of blood or rhesus conflicts and different hemolytic disorders. Serum bilirubin normally in such children drops to a low level without any intervention required. In cases where bilirubin rises higher, a brain-damaging condition known as kernicterus can occur, and it can lead into significant disability. A biliary-type is often a tool used to early treatment, which often consists of exposing the baby to intensive phototherapy. And if you saw departments for neonatals, all the bed, it's around the bed, it is lights with a very specific colored light, which is targeted to treat neonatal jaundice. Here you see an example. On the first picture, it is a child before phototherapy. Yes, you see that skin is a little bit yellowish. It is a normal physiological jaundice. And second picture after phototherapy, you see absolutely normal color of skin. Symptoms, clinical symptoms of jaundice. Yellowish discoloration of the white area of the eye and the skin. The conjunctiva of the eye is one of the first tissues to change color as bilirubin level rise in jaundice. Usually it is the earliest one because it's not very visible or not visible at all changes of skin, but we can find yellow color of sclera. Usually in some type, you remember from mechanism for which type, it can be urine is dark in color and stools or feces can be pale in color. Both last symptoms are typical for obstructive jaundice. Here you see jaundice in the same patient. It was first photo before and second photo it is after some time. Diagnostic tests. Jaundice, of course, first of all, we should diagnose laboratory as a syndrome. We use for it such laboratory signs like total bilirubin, its fraction, conjugated bilirubin, and unconjugated bilirubin. Moreover, we can check urobilinogen. We determine urine color, stool color, levels of alkaline phosphatase, levels to alanine transferase and aspartate transferase, conjugated bilirubin in urine, and presence of splenomegaly. And according to type of jaundice, is it prehepatic, is it hepatic or posthepatic, you see what the most typical changes in what signs we can see. Next syndrome for today is syndromes of liver size changes. It is two syndromes and both of them are opposite. It is enlarged liver or hepatomegaly, and one more syndrome, it is small for size syndrome. Enlarged liver or hepatomegaly. Let's discuss its causes. Hepatomegaly may be caused by alcoholic liver disease, by congestive heart failure, cirrhosis, hepatitis, liver cancer, dyslipidemias and hyperlipidemias, chronic leukocytic leukemia. It can be caused by hepatic vein thrombosis or by the also we name this syndrome Budd-Chiari syndrome. Hepatomegaly can be provoked by metabolic syndrome X, pericarditis, adult onset Still's disease, and hypolipoproteinemia. It is the most often cause. What symptoms can be clinically in patients with hepatomegaly? It is feeling of fullness, especially in the right upper quadrant of abdomen. It is discomfort in the belly. Depending on the cause of enlarged liver, patient may notice symptoms like jaundice, fatigue and weakness, nausea, and weight loss. Diagnosis of enlarged liver include, as usual, physical examination, and I hope you learn on Propaedeutics. You had a practical class about palpation and percussion of abdomen, and you remember that palpatory and by percussion during physical examination you can determine enlarged liver. And to confirm your diagnosis after physical examination, to visualize enlarged liver, for this visualization we use CT scan, MRI or ultrasound. During physical exam, normally liver is placed, remember, under the costal margin, and in a case of hepatomegaly it can be lower, like for example you see on the photo, right photo of a child with very significant hepatomegaly. You see that the border of liver decreased into the middle of abdomen. Here you see example of native CT scan that shows a slightly lobulated liver contour with ascites and dilated bile ducts and an enlarged spleen. And here MRI with a huge hepatomegaly. You see to the left in the middle it is a very big volume, very big mass of liver in patient with very significant hepatomegaly. Moreover, here we see multiple hypoechoic areas in spleen, suggesting splenic involvement. If you pay attention to spleen, it is at the right side here of the picture. In patient, of course, it is on the left side. You see more intensive colored structure, and it is some dark places. It is hypoechoic areas. And ultrasound. Here an example of ultrasound of patient with Hodgkin's disease with splenomegaly, hepatomegaly, and enlarged mesenteric lymph nodes. Here we see that it is a very big liver, hepatomegaly, and tissue of liver press on some structure that visualized like enlarged lymph node. And another syndrome, if that was a big liver, here it is a small liver, or we name it small of size syndrome. Small of size syndrome, it is a condition which causes considerable confusion, partly because the term has been extended beyond its original meaning. It was initially used to describe the situation in liver transplantation, where a patient develops liver dysfunction and ascites because the donated organ is too small for the recipient. It is a condition which causes considerable confusion, partly because now it is used before it was used just in transplantation. Now it is described any circumstance where the postoperative liver failure of dysfunction in patient who has had liver resection or partial of small graft liver transplantation. You see here the most typical methodics of liver transplantation, what lobes usually choose for transplantation, and if the donor leave not enough liver tissue, it can start small for typical classical small for size syndrome. Mechanisms of it. Small for size syndrome can occur in the special situation of partial liver graft transplantation, especially in adult living donor liver transplantation, with resultant size mismatching between graft size and recipient hepatoportal circulation. Once the partial liver volume graft is subjected to excessive portal inflow, portal hyperfusion results in the development of small for size syndrome. Symptoms of this syndrome. It is excessive ascites, hyperbilirubinemia, coagulopathy, encephalopathy, and renal dysfunction. What more I want to talk about it. The transplant recipients develop symptoms related to the above abnormalities after transplantation, and post-transplant prognosis is reported to be less than ideal. It's not very good. And one more syndrome for today, it is syndrome of portal hypertension. Portal hypertension is abnormally high blood pressure in the portal vein system, which is composed to the portal vein and its branches and tributaries. Portal hypertension is defined as elevation of hepatic venous pressure gradient to more than 5 mm hydrarchia. Causes. The same logic with jaundice. It can have three localizations: prehepatic, intrahepatic, and posthepatic. But if jaundice go from upper to down, prehepatic, hepatic, and posthepatic, portal circulation, and as a result portal hypertension goes from the down upper. It is prehepatic, it is before liver in a portal vein. after it intrahepatic in the liver, and after it upper post-hepatic, it is in the system of liver vein. Causes that can lead to prehepatic hypertension, portal hypertension. It is portal vein thrombosis or congenital atresia. The most often intrahepatic causes include liver cirrhosis, hepatic fibrosis, non-cirrhotic causes like schistosomiasis, massive fatty change, and diffuse granulomatous disease. Post-hepatic causes of portal hypertension can include hepatic vein thrombosis, inferior vena cava thrombosis, inferior vena cava congenital malformation, and constrictive pericarditis. Symptoms of portal hypertension. It is general symptoms like as weakness, tiredness, and malaise. They can include anorexia, weight loss, common with acute and chronic liver disease, ascites, hepatic encephalopathy, increased risk of spontaneous bacterial peritonitis, and increased risk of hepatorenal syndrome. Splenomegaly with consequent accumulation of red blood cells, white blood cells, and platelets together leading to mild pancytopenia. Development of varices at portocaval anastomosis, like esophageal varices, gastric varices, and anorectal varices, and caput medusa. Now I'll show you what is that. Esophageal and gastric varices pose an ongoing risk of life-threatening bleeding with bloody vomiting or melena. And here you see schematic, the most often symptoms of portal hypertension. Yes, according to severe liver disease, it can be hepatic encephalopathy. It's general malnutrition. It can be skin spider angiomata. It can be testicular atrophy, ascites, and it can be different varices like esophageal varices, to enlargement of periumbilical vein, we name it periumbilical caput medusa, and varices in hemorrhoidal vein, we name hemorrhoids. And one more time schematically, what can be affected in case of ascites. Yes, it is pressing on lungs, it is pressing of liver, of stomach, it is pressing of bowel that contains peritoneal space, it is pressing of peritoneal membranes, and it is pressing of on pelvic organs in case of significant ascites. Here are a photo examples of patient with caput medusa. You see such a specific vein varices can be, and all of them it is patients with portal hypertension. Diagnosis of portal hypertension can be done in a base of clinical symptoms. It's what we told on previous slide. According to measurement of hepatic venous pressure gradient, or HVPG, measurement of it as a gold standard for assessing of severity of portal hypertension. This test replaced the old one, contrast angiography. It was more difficult and more invasive for patients. Portal hypertension is defined as a pressure greater than equal to 5 mm hydrargum and is considered to be clinically significant when HVPG exceeds 10 to 12 millimeters hydrargum. Moreover, for diagnosis of portal hypertension, we use imaging tests, a liver biopsy and histologic examination, hemodynamic measurement of hepatic venous pressure gradients, what I told, and usually we do upper GI endoscopy especially for visualizing esophageal varices, and it is a criterion standard of assessment of portal hypertension too. It is obligatory for such patients. In such way, you see checking of hepatic venous pressure gradient. Here, it is measurement of damping index of hepatic vein waveform. On picture A, it is patient with liver cirrhosis, shows 0.26 of damping index with 7 mm hydroargon of HVPG. And second, it is a patient with liver cirrhosis, showed 0.72 for damping index and 15 mm hydroargon of hepatic venous pressure gradient. Yes, that is specific for significant portal hypertension. Visualization usually include MRI, like for example in this picture. Here we see a coronal section plane of the abdomen acquired with the true fast imaging sequence or true sequence used to define the middle segment of portal vein. And here you see a very good, you see in the left part of picture, it is a liver and it is a very good visualized portal vein. Upper endoscopy or esophagogastroduodenoscopy, you remember from previous lecture. Here you see a typical picture. It is endoscopic view of multiple large portal hypertensive polyps of the atrium or esophageal varices. You see, it is a big structure under the mucosa, esophageal mucosa. Laboratory testing for patients with portal hypertension. First of all, as for most patients, it is CBC or complete blood count. It is obligatory to done. It is liver function test, especially aspartate aminotransferase AST and alanine aminotransferase or ALT, and including bilirubin. It is indications for coagulation study. With checking prothrombin time, partial prothromboplastin time, international normalized radial. Moreover, it is checking of blood urea nitrogen, creatinine, and electrolytes, and we usually check arterial blood gas and pH measurements for check for metabolic changes. If we suspect hepatitis, especially viral hepatitis, we should do serologies, particularly hepatitis B and C serologies. We should check albumin levels because hypoalbuminemia is very common in patients with portal hypertension. It can be checking for antinuclear antibodies, antimitochondrial antibodies, anti-smooth muscle antibodies. Moreover, it is checking for iron indices, alpha-1 antitrypsin deficiency, for ceruloplasmin levels, and 24-hour urinary copper. And another syndrome for today, it is syndromes that are connected with disorders of exocrine pancreas, and especially I want to talk today about exocrine pancreas insufficiency. What main symptoms and syndrome it clinically manifests? It usually associated with diarrhea, steatorrhea, you remember it is fat in a stool. It is abdominal pain and symptoms of vitamin deficiencies. Definition of exocrine pancreatic insufficiency. It is the inability to properly digest food due to a lack of digestive enzymes made by the pancreas. Exocrine pancreas insufficiency is caused by a progressive loss of the pancreatic cells that make digestive enzymes. Causes can be pancreatic and non-pancreatic. Pancreatic causes of endocrine pancreas insufficiency include chronic pancreatitis, cystic fibrosis, obstruction of the pancreatic duct, Schwartzman-Diamond syndrome. It is exocrine pancreatic insufficiency in combination with bone marrow dysfunction, leukemia predisposition, and skeletal abnormalities. And non-pancreatic causes of exocrine pancreas insufficiency include celiac disease, Crohn's disease, autoimmune pancreatitis, Zollinger-Ellison syndrome, and GI and pancreatic surgical procedures. Pathophysiology of this insufficiency. Exocrine pancreatic insufficiency characterized by deficiency of exocrine pancreatic enzymes, which results in inability to digest food properly, what we named, remember previous lecture, maldigestion. Because pancreatic lipase accounts for up to 90% of fat digestion, maldigestion of fat is more profound in exocrine pancreatic insufficiency than maldigestion of proteins or carbohydrates. Fat digestion is not clearly impaired until lipase output decreases to below 10% of the normal level. Fat malabsorption precedes a malabsorption of other macronutrients. Bile salt precipitation and subsequent absorption to undigested food reduces the bile salt pool. And this reduction further impairs fat digestion. Undigested fat in this case, rather than being absorbed, is excreted in the feces, leading to steatorrhea. Another factor that contributes to pancreatic steatorrhea is the presence of neurohormonal disturbances, which result in gallbladder hypomotility and accelerated gastric and intestinal transit. Malabsorption of fat-soluble vitamins, remember what is fat-soluble? It is vitamins A, D, E, and K. These deficiencies may be accompanied with exocrine pancreatic insufficiency. Symptoms of this syndrome, they include, first of all, steatorrhea. You understand from pathophysiology why, because first of all it affected fat digestion. Moreover, it can be weight loss, diarrhea, it can be pale, bulky, malodorous stool, often float on top of the toilet water with oily droplet and difficult to flush. And it can be fatigue, flatulence and abdominal distension. Symptoms can include edema that here result from hypoalbuminemia or oncotic edema, and it can be anemia in such patients. And it can be either microcytic related to iron deficiency or macrocytic. It can be related to vitamin B12 deficiency. Very typical for exocrine pancreatic insufficiency, it's bleeding disorders, a consequence of vitamin K malabsorption and subsequent hypoprothrombinemia. Moreover, it's typical ecchymosis, metabolic bone disease such as vitamin D deficiency, and neurologic manifestations with generalized motor weakness, peripheral neuropathy, loss of sense of vibration and position, night blindness, and seizures. All of them typical for exocrine pancreatic insufficiency. For diagnosis of these disorders, we usually use lab tests like blood tests, 3-day fecal test, test for fecal elastase 1, and endoscopic instrumental test with CT scan, MRI scan, and endoscopic ultrasound. Okay. For exocrine pancreatic insufficiency, one of the most specific tests in a previous list was 3-day fecal test. What we usually do, it is normal range for fecal fat testing in 7 grams over 24-hour period. But it's not every day all people have a stool, and it not be the same containing of fat every day, every stool. That's why for more accurate result, it usually takes 3 days or 72 hours test, and fecal fat have been there 21 grams, not more. Testing for fecal elastase 1. The reference concentration to interpret pancreatic elastase results after the first months of life. It is more than 200 milligrams elastase per gram in stool. It is normal exocrine pancreas function. Level of from 100 to 200, it is mild to moderate pancreatic insufficiency. And level less than 100 elastase per gram stool indicates exocrine pancreatic insufficiency. For today, it is the most specific test for checking for fat malabsorption, maldigestion, and to put in diagnosis exocrine pancreas insufficiency. For today, that's all that I want to show you. If, as usual, you have difficult moments, you have questions, you have comments, I always waiting for feedback from you in the comments under the video, and if possible in our Facebook page. And as usual, I ask every student who listen my lecture, please leave your name and group number in the comments under the video. For today, that's all. See you in 2 weeks on the new lecture. Goodbye.